Welcome to the NWAETC Project Echo. I'm Kent Unruh. I'd like to turn it over to our medical director, Dr. Brian Will, to introduce our guest.
Well, it's an honor to have Dr. Joe Merrill with us today. Many of you will recognize Dr. Merrill from Hep C Echo. Dr. Merrill is a provider here at Madison Clinic and Associate Professor of Medicine and one of our addictions experts. And I will turn it over to Joe.
All right. Well, today I'm going to talk about alcohol treatment. So, obviously, alcohol use impacts HIV transmission, progression, and treatment. Adherence to heart can be compromised and toxicity increased by heavy alcohol use. So alcohol is also a major risk factor for progression of liver disease with hepatitis C and is a common barrier to hepatitis C treatment. So for those co-infected patients, alcohol is especially important. And there's a large spectrum of alcohol use and a large spectrum of problems that come up for clinicians to sort through in their practice. So I'm going to talk about steps in managing alcohol problems today, screening to identify the risk level, assessing whether patients have an alcohol use disorder, depending on the result of that, using brief intervention for those who are at-risk drinkers but do not have an alcohol use disorder, and then for patients with alcohol use disorder, considering referral or withdrawal management and prescribing of medications for alcohol dependence. So alcohol screening, do you sometimes drink alcoholic beverages? If the answer is no, then really all you're trying to fish for is whether they have a history of problems. And the reason they're not drinking is that they've had a severe alcohol problem. So have you ever tried to cut down, or have others ever been concerned about your alcohol use? As one approach to that. You can use other approaches, but that's one way to go. If folks do drink alcohol, the one single question that works best in primary care settings is the binge question. But how often have you had 5 or more drinks in a day? If that's for men, and 4 or more drinks in a day for women. If the answer of that is anything but 0 from never, then you need to go further. But if they're not binge drinking at all, then you can stop in your alcohol screening. And then calculating a weekly average, just sort of by how many days a week you're drinking, how many drinks per day kind of thing. And what you're looking for is whether the patient is staying within safe drinking limits. So 4 drinks a day or for men, or 3 drinks a day for women is above. I think I did that wrong. No, that's right. That's right for the level of binge drinking. If they have a man has 4 drinks one day a week, that would be under the 14 drinks per week limit that is what we consider safe drinking. So 14 drinks a week for men, 7 drinks a week for women. There's a lot of differences in the metabolism of alcohol between men and women. And so that explains the differences between what we call safe drinking limits. If patients have hepatitis C, of course, those safe drinking limits go away, kind of like in pregnancy, and we really have no established safe drinking level for either of those groups. So you're trying to figure out if they're drinking over recommended amounts, and if they are, then you have another step to do. You know they're at least an at-risk drinker, but you don't know whether they have an alcohol use disorder. DSM-5, which is very recent, has changed some of the criteria around addiction-like diagnosis, and have actually taken away substance dependence and substance abuse. Those categories no longer exist in DSM, and it's been replaced by substance use disorder. And the criteria for a substance use disorder are listed here. I'm not going to go through all of them. They're the same ones as those that were applied for alcohol dependence and alcohol abuse in the past, with only a couple of exceptions. The second to bottom one, the craving question, such a strong urge that you cannot think of anything else, that question is new. That wasn't in the old criteria. And really the only other difference is apply to, not to alcohol, but to prescription drugs that may be being used and may cause tolerance or withdrawal, but are used appropriately in medical practice. That's a difference, not for drug abuse or drug use disorders. Not so, doesn't apply to alcohol. So those are the criteria. And then the only other thing that's different about DSM is now they have a severity estimation categorization. So instead of having the abuse dependence, where dependence was worse than abuse, we have these categories of, if you only have one criteria, you actually don't meet criteria for substance use disorder. And then you can see mild, moderate, and severe. If you get six or more, you're in the severe category. So you're trying to decide for these folks who are at-risk drinkers whether they meet these criteria, because it's going to affect what you do. So for those who are at-risk drinkers but don't meet criteria for an alcohol use disorder, then your goal is really to inform the patient, give them feedback about their drinking. You're drinking more than is medically safe. And I strongly recommend that you quit or cut down. Basically, giving feedback, giving advice, and then assessing willingness to change. So are you willing to change your drinking? If folks are not in that space, then it's worth to take a minute or two just to encourage folks to reflect on the pros and cons of drinking, restating your health concerns. And if you can apply those health concerns as specifically as possible to that patient, if they have dyspepsia, if they have hypertension that's made worse by alcohol, if they have whatever alcohol-related health problems that patient has, you want to restate those more specifically for the patient. And then reaffirm your willingness to help them if they ever want to make a change. And just so they know what the safe limits are and what you recommend. If they are willing to change, then the goal is to set a plan, set a goal, agree on a plan, and do some problem solving around what's going to get in the way of that plan. Either one, you want to be doing some kind of support and follow up. I generally write in my note, alcohol use disorder or at-risk drinking, and then where we got to in our visit, just so I know the next visit. So how did you do with that plan? Or if there was no plan at all and the patient was not wanting to change, then you know where you got to the last visit. So for folks who have alcohol use disorder, then again, you're giving feedback. You have an alcohol use disorder, and I recommend that you quit. The cutting down, recommending cutting down for a patient who has a alcohol use disorder has not been shown to help that much. So you can negotiate a drinking goal with none being the safest, and you can talk to people about trying to drink less. But in general, the evidence shows that for physicians who giving advice in a medical practice setting, that if somebody has an alcohol use disorder, a brief intervention like what I described for the at-risk drinkers doesn't seem to be that effective. So spending a lot of time on that's probably not worth your time for those folks who have alcohol use disorder. Doesn't mean you ignore the problem. It means that you're not sort of aiming at a brief intervention and calling that your intervention, because those brief interventions work for folks who are at-risk drinkers, but they don't necessarily in this setting work for folks with a more severe problem. For those folks who have an alcohol use disorder, considering an addiction evaluation or that goes into more detail about how alcohol is affecting folks' lives, like are there legal problems, are there family problems, are there employment problems related to alcohol. Those are reasonable things to either do yourself or to get someone else to do. Recommending that folks try AA or some kind of mutual help group. It doesn't have to be AA. There are programs like Rational Recovery for folks who really don't like the higher power aspect of Alcoholics Anonymous, but that provide mutual support for folks who have had problems or are thinking about changing their alcohol use. The other things to check in about that affect the medical treatment of folks with an alcohol use disorder is to assess the need for a medically managed withdrawal. So do people, as part of your evaluation for alcohol use disorder, you're going to ask them whether they get shaky in the morning, whether they need a drink in the morning, some version of do they start to have withdrawal, and then you can assess further as to how severe that's been in the past. And really, the major predictor, the only predictor really of having a more medically severe withdrawal is whether people have had it in the past. So if people have been hospitalized for withdrawal or had gotten delirious or had a seizure, those are very high-risk patients, and you don't want to be telling them to stop drinking by themselves. You want them to be getting help with a detox. And then the prescription of medication for alcohol dependence is the fourth area to consider for folks with alcohol use disorders. And those medications are very underused in medical practice. And I'm going to talk about them basically for the rest of the talk. Always arrange follow-up for these folks as well. You want to be giving them feedback, positive or negative, about how they're doing with their alcohol and how it relates to their health. So the FDA approved medications for alcohol use disorders are listed here. Disulfiram or antabuse, Acamprosate, which is Camprol, and then Naltrexone, which exists in both oral form as Revia or intramuscular as Vivitrol. There are a number of non-FDA approved medications, which I'm not going to go into detail about, but just know they're there. And topiramate, Topamax, there's actually quite a high level of evidence, and it probably would be approved by the FDA if it had been submitted for FDA approval, but it's gone generic, so it is not going to get that designation. But it does have good evidence. Varenicline, there's a single recent positive study for varenicline. It looks like it works pretty much equally well in smokers and non-smokers, so it doesn't have to be for people who both smoke and drink, but it's an interesting study. And then gabapentin with naltrexone has also been shown to be somewhat effective. There's a study of the combination of those two. And then gabapentin also may have a role in folks who are who are coming out of a detox for sort of prolonged withdrawal symptoms for at least a few months. Baclofen, some mixed results, and a bunch of others that have been studied. So disulfiram produces an acute sensitivity to alcohol. The randomized trials do not show much of a benefit. It's kind of FDA approved as a sort of grandfathered in. And it may be effective if you've got patients who have some way to have the adherence to the medication monitored. You can't begin disulfiram until 12 hours after the last drink. The dosing is there. There is some liver toxicity. So folks who have Hep B, Hep C, you have to use it with some caution, although haven't seen tons of toxicity. You just want to check before you start and check again after a few weeks or a month. Acamprosate or Camprol has a different mechanism. It blocks the release of glutamate, which is associated with alcohol withdrawal. And the data looks like it's a little bit more helpful in keeping people from relapsing as opposed to reducing their drinking levels. And we'll talk a little bit more about that with naltrexone. It does not prevent alcohol withdrawal. The dosing is a little cumbersome at 3 times a day. And there are some side effects. It's actually quite well tolerated and has absolutely no liver toxicity. So folks who you're really worried about their liver, this is a safe drug. Naltrexone is probably our first line for alcohol dependence. It blocks the mu-opioid receptor and weakens the rewarding effect of alcohol. This is a drug that looks like it reduces the level of drinking. It may not have that much effect on abstinence rates, but it looks like the number of heavy drinking days, the number of binge drinking days appears to be the measure that's most closely associated with medical complications of alcohol. So being able to reduce the level of drinking is potentially very helpful in reducing medical complications. Starting at a dose of 50 milligrams, you can push that up to 100. There are some side effects. It's also pretty well tolerated. Transaminitis is on the label. although it really may not cause that at all. So I wouldn't worry about naltrexone liver toxicity. The extended release version of naltrexone is a once-a-month injection for alcohol dependence. So I'm not going to go into this too much. This is an example. There's an overall men and women. These are the left-hand bar in each column shows drinking levels before treatment, and then the 3 bars on the right of each column there shows levels of for placebo and 2 doses of naltrexone. As you can see, just getting a medication for alcohol dependence seems to be associated with a big reduction in drinking. And then there's statistically significant differences with the placebo versus naltrexone versus higher dose naltrexone. But you can see that's a smaller difference. So getting people to take a medicine for alcohol dependence is associated with a big reduction in drinking. Choosing medications, the naltrexone, it can be used in active drinkers. You don't have to have people sober. And family history and increased craving may be predictors of response. Acamprosate, very safe in liver disease. And can be used with opioids. Obviously, naltrexone blocking opioid receptors, you can't give it to patients who are taking opioids. For acamprosate, maybe some predictors of response, having more anxiety, more withdrawal may predict that, but it's not, none of that is very clear. And disulfiram really only in highly motivated and hopefully supervised adherence. Genetic markers are something people are looking at to see if some of these medications may be more effective in some folk, depending on their genetics. Some models that we're studying to try and help patients with alcohol dependence. Collaborative care for alcohol dependence is a trial we're doing it through the VA. It's really modeled on the depression and anxiety trials that have been effective in primary care settings. What we do is have a research nurse or a nurse interventionist, who does some outreach and basically chases the vets around and calls them up and tries to meet with them. And then that nurse has access to a panel much like the ECHO panel of multidisciplinary expert advice to help that nurse. And if medications are needed, there's ways she can get the patient medications. Emphasis is on medications, on lab monitoring, showing patients that if they slow down or stop, that their transaminitis improves, that their CBC looks better, etc. And this is an ongoing model that we're studying now, and it really looks interesting. I suspect it's really going to work. And then a more harm reduction model we're also involved in. We're doing at the sober housing, 1811 East Lake here in Seattle, is a housing first model where folks who are actively drinking can get a place to live as a first step towards improving their lives. And we're giving naltrexone there. So once monthly injection of naltrexone. These are people who are chronically very, very severe alcoholics. We're using, an outreach and engagement approach, focusing really on a harm reduction kind of counseling, not telling folks that they have to stop, really wherever they're at, trying to get them to improve, and really focusing on drinking reduction, not necessarily abstinence. So alcohol treatment, it begins with screening and determination of risk, whether folks are at-risk drinkers or have alcohol use disorder. For those who, for those patients who are drinking above recommended levels, you need to assess for alcohol use disorder. Brief interventions, really a great skill to cultivate and learn. These are effective in reducing drinking and the medical consequences of drinking for patients who have at-risk alcohol use, but those who don't have alcohol use disorder. And then for those folks who have an alcohol use disorder, medications are effective. They're very underutilized, and really we should be pushing these for patients who have alcohol use disorder. I didn't change the word alcohol dependence to alcohol use disorder, which I should have, to make sure that DSM-5 is appropriately cited. So I think that's it for my talk, but I'd be happy to take some questions, a brief run through alcohol treatment.